Now for the last talk, now I invite Dr. Mahesh Gopalakrishnan, Senior Retina Surgeon at Giridhara Institute, for his presentation, Case-Based Scenarios from an Eye of an Expert.
To the President, sir.
Okay, that title was given by him. I am not expert. This is one quote from WhatsApp University. Doctors, especially surgeons, are simple souls. Their basic needs are OT, Kapada and Makan. So this I got from one of the thing. So we people think that we are gods and we can treat anything. Unfortunately, every day we burn our hands with the diabetic retinopathy. At the end of the day, we will think, why the bloody hell I took this case. So this every day we think. That's the problem with diabetic retinopathy. We are fighting a diseased retina. A surgeon in first 10 years of career learned how to do surgery, many of us. Then next 10 years when to do surgery, and last 10 years he learns when not to touch the patient. So this is the time. I am into that last third decade. So that's why Anubhav gave me this talk. So there are ever expanding surgical indications, no? Non-resolving teratoma, TRD, CRD, totaloid, non-responsive DME. And then with technology advancement, we have, me and Dr. Giridhara have done one case for 5-6 hours, both of us together in tandem. So now none of the cases go beyond 1.5 hours because the technology advancement, 25, 27 gauge, and demanding patients, aggressive surgeon, all these are there. But we learn lot of things by mistakes, by committing. So basic principle of any treatment is primum non nocere. So do no harm to the patient. Why? I will tell you some examples. There is no surgery with 100% success rate. Latest technology, we analyzed our own results. Out of 100, 95 did okay, stabilization or improvement, but 5% fails. If it fails, it is no PL in diabetic retinopathy. If the surgery fails in diabetic retinopathy, it is no PL. And some of them from county finger 1 meter has become no PL also. So unlike RD, we are fighting a vascular compromised retina. That's the problem with DR. A lot of things depend on the metabolic conditions. Deteriorating renal function will reflect in the eye. Like that, lot of things are there. And putting silicone oil is not the end of the surgery. That is another thing I always tell. You can consider PDR surgery successful if you complete the procedure with silicone oil removal and patient is having stable vision and normal IOP. In most of the conferences, people show the video once they put oil and show the picture. The vision will be only 1 meter. I know. With silicone oil, it will be only 1 meter vision. Okay, so likewise, DME stabilization, vision at maximum possible level should be the goal. Some patients, 1 meter, 2 meter vision may become 660, that is fine. 660, it remains at 660, that is fine. So vertical follow-up is the important thing. So as I told, sometimes we think why I treated this patient. You have to decide based on you knowing your own limitations. So risk-benefit analysis is what is needed. And in one-eyed patient, this is very, very important. An ambulatory patient with one eye, you just decide whether you can do better job or improvement. Otherwise, don't touch that. So when you do treatment, it should improve the patient condition, or at least it should prevent further deterioration. That is the dictum. So there are two types. One is absolutely no doubt, combined RD, non-resolving vitreous hemorrhage, you have to treat, nothing. But some of the chronic cases, chronic DME or chronic TRDs, you need not take it for surgery or injection. Be careful when it's one-eyed and end-stage PDR with ambulatory vision. Pre-treatment vision may be better than post-treatment vision. And there are some things that we miss when we look at the patient. Optic atrophy and macular ischemia. You do a fantastic job. Finally, vision is not there. One of these causes will be there. So I will tell you few cases, examples. Right eye 6/60, left eye already blind. So this is the patient referred to me as a TRD, threatening macula. Fine, correct. As per the textbook, you have to operate this, right? Vision is 6/60, one-eyed. And this picture itself shows that it is a chronic fibrous tissue and it is there for quite some time. Look for the history, and this is the picture. What are you? See, all schisis of retina traction. So theoretically, as per the PG question, it is an indication for surgery. But if you do surgery, put oil, the 660 is further going to lose, and finally it will become atrophic macula. So, should you laser? Should you remove them? Can you remove them? All these things, if you give laser alone, that is also going to worsen. So, these sort of cases better not to touch at all. So, that is the most important thing, rather than jumping into laser or surgery. Another case, 13-year-old, right eye defective vision for a long time. So, I did this one, the right eye was long time, actually hand movements vision, left eye had reasonably good vision. So, this was the picture, like TRD, and I tried everything, silicone oil removal and cataract surgery, it remained at hand movements, because I said optic atrophy is there. So, learning points, history is very important. You ask the patient how many years he is having defective vision in that eye, is it recent worsening of vision? Otherwise, if it is recent worsening, fine, or your own patient coming back with loss of vision, fine. Otherwise, unnecessarily don't take findings like subretinal fibrosis. And I always tell this line to my people, treat with your brain. You feel very empathetic, oh poor patient, we will try, don't do that in diabetic retinopathy. You treat with your brain, you think that whether you are going to give improvement, treat, otherwise don't touch. So, not with your heart, okay. So, that is one thing that I always tell. Then this is another case, diabetic. So, these sort of cases, are we going to improve with injection or even surgery? See the drill and then ellipsoid loss in the macula. There is so final visual assessment you have to judge based on the OCT biomarkers. So even if you give injection, there is ellipsoid is completely gone, photoreceptor layer also is gone. So think about that possibilities and then advise injections. So history is very important, recent worsening is important. Always if you have a doubt, call again after 1 month, re-examine for documentation of deterioration rather than jump for laser and surgery. So that is another thing. Recent nephropathy worsening. Today it is 1.9, next month is coming 2.7, then 3.4. Like that, creatinine is rising and he is having deterioration of vision. Don't jump into surgery. You are going to burn the hands. Okay, 100%. So even the nephrologist will be thinking that he is going to get into problem. So these sort of cases, even if you do surgery, post-surgery, left eye had hand movements only, even after good surgery. So right eye was gradually getting bad. I didn't touch that eye. Later patient underwent a transplant and later he improved significantly, automatically, without anything. So poor outcomes in deteriorating, nephrostatus is very important while deciding your surgical treatment or laser treatment. So another case. So this is another PDR, but again I am telling you, vertical follow-up is the best predictor for outcome of VR surgery. Don't jump into conclusion when you see that this patient had similar finding for many years. So there is no point in giving surgery at this, somebody has advised surgery and again send the patient, you go and do surgery. So the problem is the people who advise all these things have much less experience than ourselves. That is the problem. They just, so you have to use your brains and then decide rather than take up for surgery. So out of proportion visual loss, think about old AAO in or macular ischemia. Old records are important. Sometimes I ask the patient, do you have any vision testing of 2 years back? Then they will bring one medical, hello? Yeah. Old vision recording picture or old vision records. It will show that it was only hand movements 5 years back. So all these things are most important rather than, then some patients are extremely, they go for naturopathy and all this stuff and then they don't take any medicine. These are patients, if you do treatment, they are going to worsen only. So this, like one patient, they had actually threatening macula, TRD, and patient had stopped everything, 400, 500 sugar on naturopathy and all this stuff. So I said, you control that and then only we will, otherwise it will get infected. I said, it will get infected. So then he got, then gradually it settled automatically. To my wonder that TRD settled, I don't know why. But after 2 months of restarting treatment, the macula became flat. I was also, anyway, so you have to scare the patient to some extent so that they take care of their health. So when not to laser, every time there is a bleed, this is another thing that I want to tell. Many of our medical retina people, already enough laser is there. What is enough laser is different question. Again, little blood, then they will give one more laser. So 14 times laser, 16 times laser. These are all, we are doing this. We means all of us. So that is why I am telling, unnecessarily don't keep on lasering and little view spots. Every bleed does not require laser. So part of, sometimes the bleed are due to the PVD pulling the new vessels. Yeah, and lot of fibrosis don't laser. Even if you don't laser, it is okay. And and another thing is, what do you expect with laser? Your new vessel will never disappear. Okay, your new vessel, that vascular element will become little fibrotic and it will remain there. It is not going to disappear with laser. So don't expect all these things when you do laser. And when not to inject, we are told biomarkers, extremely important. Think about that and then only give the injections. Tractional DME, there is no use of injection. And don't treat CMT. You treat the maculopathy, the central macular thickness. A lot of people, central macular thickness increased, inject. If it is not increased, don't inject. So chronic cases, and in chronic cases, when you see the patient for the first time, don't jump into injections. There is no urgency in treatment, especially bilateral injections are not needed actually. I don't give bilateral injections this week, this eye, that week, next eye. I don't give. I give one eye and then treat 1 month, see the patient and then only start treatment in the other eye. So these are all individual preferences. When not to operate, I already said, lot of examples, no PL, hypotony, rubiosis, like that. So why we fail in PDR surgery? Surgeons can treat anything other than the cause. And some wounds are made worse by treatment. So this is a basic principle, better not to touch them when we... So in conclusion, there are some cases where the natural course of treatment may be, natural course of the disease may be better than our surgical result. There are some cases we will not be able to give any improvement in quality of life or quality of vision. In those cases, just take a second look or a second opinion. Disclaimer, these are my personal opinion and not based on my own experience. Thank you.
Thank you, sir. Thanks a lot for such an elegant talk at the end.